is the extent, upper and lower extent of the face. And we are getting the tragus here, tragus of the ear, external ear, from here up to the midline. So this is the extent of the face. Now what is the magic in face? First, it has got no deep fascia. Only superficial fascia we get, and that too is absent over the eyelids. So nature has purposefully made this arrangement. If there is deep fascia, we cannot express. There are some non-verbal expression which can be created by contraction of the different group of muscles. Now, so if there is deep fascia, there would be no expression. Expression will get hindered. So this is definitely an advantage. But can you tell me what is the disadvantage? The face has got no deep fascia. It has got only superficial fascia. There is no deep fascia. Definitely this is an advantage, so that we can express our emotion. But what is the disadvantage? Can anybody tell me? Can anybody? Try. Absence of deep fascia. Any infection in face can rarely go inside. Okay? It can go rarely inside. Where it can reach within the cranium, there are some cranial venous sinuses, intracranial venous sinuses. Like one of them is very important, which is called cavernous venous sinus. That means it's a vein. So it is present intracranially. So there is another venous plexus which is present within that head neck region, that is pterygoid venous plexus. You will know gradually there are pterygoid process in the sphenoid bone, and it is that venous plexus is in relation to that pterygoid venous plexus. So infection through the facial vein, it can go inside readily because there is no deep fascia. And there are other causes like the facial vein, it has got no valve. So if there is no valve in the facial vein, so infection can reach inside readily. Because it can, the blood flow might be, there will be forward and retrograde flow of blood. So through the retrograde flow of blood, it can reach the intracranial venous sinuses and pterygoid venous sinuses. Now here we can see the peculiarity of the skin. First, it is very much vascular. There is one vein which we can feel if we can taut this muscle or clench our teeth. We can find one muscle which is called the masseter muscle. And just anterior-inferior part of this muscle at the junction between the masseter and the mandible, we can feel the pulse of the facial artery. And this artery is coming from external carotid artery. There are several branches of the external carotid artery. Actually, the common carotid artery divides into two branches. One is external and one is internal carotid artery. This external carotid artery again divides into several branches, like superior thyroid artery going towards the thyroid gland, ascending pharyngeal artery going to the pharynx, then lingual artery going towards the tongue, then facial artery which may arise as a common trunk, which might arise as a common trunk, which is called linguofacial artery. Then there are other artery like occipital artery, like maxillary artery, superior temporal artery. You will know gradually during the dissection of the neck. So this facial artery, after taking origin from here, it passes through the neck. It is in relation to the greater cornu of the hyoid bone, the midline bone, just below the mandible. This is a hyoid bone, which has got two cornu, one body and two cornu. So it is in relation to the cornu, and then it goes out and ultimately reaches in the group between the submandibular gland and the mandible. In between the mandible and the submandibular gland, there is one muscle, that is medial pterygoid muscle, reaches there. Then it comes down and goes down and reaches to the base of the mandible, and it again comes in relation to the anterior-inferior aspect of the masseter muscle. So this artery ultimately gives several branches. There is anastomosis between this external carotid artery, and ultimately it artery reaches at the angle at the inner canthus of the eye, and there is a communication between this facial artery, that is an artery coming from the external carotid artery, and there is an anastomosis between the external and internal carotid artery. How? The ophthalmic artery is a branch from the internal carotid artery, and there are some branch, that is a dorsal nasal branch comes out, and there is an anastomosis between this dorsal nasal and the terminal branch of the facial artery. So this is the side between the anastomosis between the external and internal carotid arteries. So it supplies the face, and that artery is very much tortuous. This artery, you can see the facial artery, that is very much tortuous. It is taking origin from the, you can see, You can see this is external and this is internal carotid artery. From here you can see there are several branches coming out from the external carotid artery, superior thyroid, lingual, fascial, occipital, posterior auricular, then ultimately superficial temporal and maxillary artery. So we can find this artery in here, and it is tortuous and ultimately reaches at the inner canthus of the eye. And it can give several branches like superior label, inferior label, labial and other arteries throughout the face. Now why this artery is very much tortuous? Continuously we are opening our mouth. That means depression of the temporomandibular joint. Again we are closing. That is elevation of the temporomandibular joint. So there might be a shearing stress which this artery can bear. This artery bears. Like the splenic artery. We can remember the splenic artery that is tortuous because it is present in the stomach bed. Similarly, there is a stress even during the movement of the muscles and movement of the temporomandibular joint. This is temporomandibular joint. When it opens and it closes, depression, elevation. So there is continuous shearing stress. To bear that stress, nature has provided this tortuous fascial artery, especially up to the junction between the superior, after the superior labial branch, it becomes straight. But up to that, it is. Now there is a corresponding vein, fascial artery. When fascial artery is there is a fascial vein. Fascial vein, you can see that this is artery and this vein remains more medially, more towards the temporomandibular joint, and there is an axis of the temporomandibular joint. How we can get? There is one mandibular foramen in the mandible on either side. So if we join these two mandibular foramen, that is the axis of the temporomandibular joint. So fascial artery, fascial vein is towards the axis of the joint. So the stress is less. So nature has provided a straight pattern of the fascial vein. Fascial artery is tortuous, whereas fascial vein is straight. Sorry, you can see. This fascial vein is very important. It is not tortuous because it is towards the temporomandibular axis of the temporomandibular joint, whereas the fascial artery is away from the axis of the temporomandibular joint. So fascial artery is tortuous, fascial vein is straight. Now what is the peculiarity of this fascial vein? First, this fascial vein does not have any valve. So blood can flow on either side. That means you can see it is originating from the supratrochlear and supraorbital vein. And there is, and you can see one vein inside, which is a superior and inferior ophthalmic vein. So through superior and inferior ophthalmic vein, it can go inside the cranial venous plexus, that is dural venous plexus. Within the dura mater, there are some venous plexus. Among them, one is very important, that is cavernous vein, venous sinus. You will learn. So, if there is no valve, so blood may either flow in this way or it may flow on either or just opposite way, and it can reach the cranial venous plexus. So we can this is the angular vein. Actually, angular vein is continued as facial vein. Supratrochlear and supraorbital vein, you can see above, it forms the angular vein which is continued as facial vein. And there is another communication between this facial vein and you can see there is another through deep facial vein. There is a communication in which is called the pterygoid venous plexus. And again through this pterygoid venous plexus, through the emissary vein, it can reach into the intracranial venous sinus. So infection, if there is a cut in the facial vein, there is a chance of infection. So the bacteria can reach from here to this area, there is pterygoid venous plexus, and through pterygoid venous plexus, through the emissary vein, it can reach into the intracranial venous sinuses. That is cavernous venous sinus. Next is the thickness of the facial vein is more than the thickness of any other other veins. So if the vein is cut, what will happen? It will not retract. If the venous wall is very thick, so it will not retract. So it will bleed profusely. Yes, we can see during our operation of the lacrimal sac, we cut the angular vein, then it bleeds profusely. And there is a chance of air embolism. So these are important clinical anatomy you should know, you should keep in your mind. So, now what is the dangerous area of the face? Dangerous area of the face means this upper lip. Okay. Around the ala of the nose, nasal septum, like a triangular area, which is called the dangerous area of the face. Because infection from here, it can readily go inside. Okay. Now this face, ultimately what is the fate? It joins with another vein. Here we can see this is superficial temporal vein and this is the maxillary vein, which ultimately forms a vein which is placed behind the mandible, the ramus of the mandible, which is called behind the mandible retromandibular vein. Do you find any vein divides into its branches? Generally, the tributaries continuously joins and rejoins. Ultimately, the vein is formed and it reaches towards the heart. So, this is another exception in the body. After formation, it divides into two branches. Like portal vein, we know it is coming from the GI tract. Portal vein. It is formed by superior mesenteric vein and splenic vein. But within the liver, it is again divides, subdivides, and ultimately it forms the ultimately we get the sinusoids. And then again hepatic vein is formed. So this is another exception in the body which divides into anterior and posterior division. And this anterior division of the retromandibular vein joins with this facial vein, and ultimately we get the common vein, facial vein, and ultimately we drains into the internal jugular vein. So there are several relations. There is superficial relation, deep relation. I am not going into that area. Unless and until you see the body, you cannot remember. Superficially, I should say, if I say the skin, superficial fascia, okay, then we can get the platysma. Can you remember it? No. The deep relation, there are the others muscles, okay, like zygomatic major, zygomatic minor, you will not understand because unless and until you have any idea. So I am not going into the relation just now, but you should know. Next. So this is the dangerous area of the face, what I have already discussed. Okay, so this is another very important question which comes in your examination. That is the dangerous area of the face. Upper lip, the nasal septum, ala of the nose, this area, triangular or quadrangular area. Because you can see that already I have told you the anatomical basis, vein is devoid of valves, communication with the cavernous sinus. Directly through the superior and inferior ophthalmic vein, indirectly through the pterygoid venous plexus. Now this is the lymphatic drainage, you may or may not remember. So there are some groups of lymphatics which are present behind, that is, which is present on the posterior triangle of the neck. Neck is divided into anterior and posterior by this sternocleidomastoid muscle. So this is the occipital group of lymph node. Pre-auricular, post-auricular means around the auricle. So these are some lymph nodes. And here we can see just below the mandible, below the mentum of this area is called the mentum. When you will learn the osteology of the head and neck region, that is the mandible, you will learn this is the mandible, this is the mentum. So this is submental group of lymph nodes. From here, actually it's a circular chain of lymph nodes. Okay, and through this, we ultimately, this is the superficial group of lymph nodes, and it reaches into the neck. There are lymph nodes around the jugular vein. internal jugular vein, whether deep jugulodigastric and jugulo-omohyoid group of lymph nodes, which are the deep set of lymph nodes from superficial to the deep. Now, this occipital group of lymph node is very important. Infection of the scalp, which is not very uncommon. Even it is very much common in yours. Dandruff, seborrheic dermatitis, many of you may suffer. There is continuous itching. Okay. There is excoriation, minute bleeding spots, infection, and ultimately that can reach into the occipital group of lymph nodes. On some day you might get very much frightened and it might come to the surgery OPD, sir, I have some lymph nodes here, sir. Or madam, I have got some lymph nodes here. But those lymph nodes are basically due to the infection of the scalp. Most benign in nature, but most troublesome. Those who suffer from the seborrheic dermatitis or which you often call it as a dandruff. And this pre and post auricular lymph nodes, and they are swollen in several viral infection. Viral conjunctivitis. When we find the viral conjunctivitis, we examine not only the eyes, not only the corneal reflex we test, but also we test the pre and post auricular and ultimately the submandibular group of lymph nodes. The submandibular group of lymph nodes, when it is swollen, in caries tooth, or during tonsillitis. She is giving me a hint, tonsillitis, yes, tonsillitis, pharyngitis, through which it can reach the submandibular group of lymph nodes. Okay. Submental, again infection in the lower lip, it can reach. I am not going into the development. These muscles of the face develops from the second branchial arch. You will learn gradually the first branchial arch, second branchial arch. These are like this. There are some arches which develops around the upper part of the pharyngeal wall, which are called the pharyngeal arches. Suppose this is the pharynx, developing pharynx, and around which some arches, 6 arches are formed around it, like this. First, second, third, fourth, fifth, sixth. The fifth arch appears to disappear. The first arch is called the mandibular arch. Second arch is called the hyoid arch. That means first arch. Mandibular arch means mandible is formed from the first arch. The hyoid bone is formed from the second arch. This arches has got outer ectodermal component, inner endodermal component, and in between mesodermal component. From the mesoderm, muscle will arise. So the muscle of the first arch are basically, they are the mandibular arch. They are supplied by the mandibular nerve, and they are the muscles of mastication. First arch, like temporalis muscle, bosho na, suno na. Temporalis muscle, first arch muscles are temporalis muscle. Masseter, that means muscles of mastications. During eating, there is grinding. We open our mouth, then starts grinding. So these are the muscles of mastication. That means temporalis muscle, masseter muscle, medial and lateral pterygoid muscles. These are all called the muscles of mastication. Those are developed from the first pharyngeal arches. Now the muscles of the second, or from the hyoid arch, from which the hyoid bone is formed. Because each pharyngeal arches gives some muscles, some bones, and they are supplied by some nerves. From the second arch, all the muscles of facial expression, except the masseter, all the muscles of the face are developed from the second branchial arch. So the muscles are around, actually around the eyeball, around the oral aperture, and around the scalp. And another muscle which covers the face, covers the neck, it is continued up to the second costal cartilage, that is the superficial muscle, which is called platysma. When we contract, we can see the platysma. The superficial subcutaneous muscle, like that muscle which we can see in case of cow or any quadrupeds. They can, suppose in the body some fly or anything is sitting, there is jerky movement because there is subcutaneous muscle. So similarly, this is a subcutaneous muscle, which is the platysma. So some muscles, within the face, some muscles are around the eyeball. That is orbicularis oculi. Some muscle is around the orbicularis oris. Okay. Now we can see ছবিটা now we can see, so this is orbicularis oculi and this is orbicularis oris, and another muscle we can see from here, okay, is covering the scalp, and it is continued behind as a cranial epineurosis, and behind it is the occipitalis, fronto-occipitalis muscle. It covers the scalp, and in between we are getting the epicranial aponeurosis. Aponeurosis, you know already, external oblique aponeurosis, internal oblique aponeurosis, tendon sheet like. You know what is epicranial aponeurosis, what is the clinical importance, what is the scalp, CALP, you will know. But this, you can find this frontalis muscle, behind we will get the occipitalis, and here we can get the most important muscle, that is the orbicularis oculi. This orbicularis oculi has got three components. One, orbital component. That means taking origin from the orbit. The next one is palpebral component, which covers the eyelids. And one is lacrimal component. Three groups of fibers are there. That means which taking origin from the lacrimal crest, which covers also the lacrimal gland. So as a whole, the function is constriction. And you know, you should know all these muscles of facial expression, they are supplied by the facial nerve. The muscles of facial expression, except the masseter, it is supplied by the facial nerve, because these muscles are taking origin from the second hyoid arch or second pharyngeal arch, whose nerve supply is facial. Each arch has got separate nerve supply. Okay. Another muscle we can find around the oral aperture. So this is called the orbicularis oris. It has got some intrinsic muscles taking origin from the mucous membrane and inserted here. And we can get some extrinsic muscles like zygomaticus major, zygomaticus minor. We can find levator labii superioris, alacinazi. These are some muscles we can find. Again, we are getting levator angulioris and levator labii superioris, which are coming from above and inserted. So this is the function is elevation of the lip. During opening, elevation of upper lip. Similarly, in the lower part we get this depressor angulioris, depressor labii inferioris, mentalis, and below we can find a sheet of muscle which is called platysma, which is continued here up to the face as rhizorius muscle, which is continued in the face as rhizorius. Another group of muscle we can find above, which is called the procerus, and here we can get another muscle which is corrugator superciliaris. So we can get so many muscles of facial expression. This is the origin of those muscles, you can remember. So in this figure you can see this is the platysma which is continued above. This is the depressor angulioris, depressor labii inferioris, mentalis. Okay, these are muscles, and some muscles are around the ear. One is in front, one is above, one is behind. Okay, so they are called auricular posterior, auricularis superior, auricularis anterior, and in the middle, in between the orbicularis oculi and oris, we can find another muscle which is called the buccinator muscle. Trumpet, it is the muscle of the trumpet blowers. buccinator. This buccinator is origin is very important, taking origin from both the maxilla and mandible, opposite the molar teeth, and ultimately it is inserted over the lateral angle of the lip. It has got upper uncrossed fiber, lower uncrossed fiber, and in between crossed fibers. Okay, so muscles of facial expression is supplied by the facial nerve, and facial nerve of one side is affected, then one side of the face will get paralyzed. Mask face, and the angle will be deviated to the opposite side, like this. Patient will not be able to close his or her eyes. During sleep, it will remain open, which will cause exposure keratitis of the cornea. Buccinator muscle, which helps to keep the gum against or to keep the cheek against the teeth. So within the vestibule of the mouth, there will be no accumulation of the food. So when it will be affected, the accumulation of food within the vestibules of the mouth. So, and there will be continuous salivation from this side, if this side is affected. So this is called facial palsy. The extracranial part of the facial nerve, when is affected on either side, it is called facial palsy. Or Bell's palsy. Okay. নাকটা দেখাই একবার, দেখিয়ে দিয়ে ছেড়ে দিই। So these are the muscles. নার্ভসটা আছে? So these are the features of the Bell's palsy. There will be no contraction of these corrugator superciliaries, and there are the transverse wrinkling. Generally, there is transverse wrinkling. When patient is asked to clench his teeth, patient is asked to blow his cheek, the patient is asked to close his eyes, we can find the difference. When patient is asked to corrugate the upper part, this part will, if the paralysis is on this side, this part will get, will be no development of any wrinkle. When we are disgusted, what we do? There is contraction of this part just above the eyebrow. This corrugator superciliaris. So the sign of disgust will be absent. That is called mask face. Inability whistling. That means due to the buccinator is affected. Now this facial nerve, the extracranial part of the facial nerve gives 5 branches. Like this. One is, the upper one is temporal branch, zygomatic branch, buccal branch, mandibular branch, and this is the cervical branch. So facial nerve is divided into these branches. Okay, and they supplies, like temporal branch supplies this area, that means temporalis, auriculus anterior. Zygomatic branch supplies the upper part of the that means the orbicularis oculi. From the buccal branch, the lower part of the orbicularis oculi, and from the lower buccal branch, this upper and lower from the lower buccal branch, it will supply this area, that is upper part of the orbicularis oris. And from the mandibular branch, lower part of the lower part of the face is supplied, and the cervical branch goes down and supplies the neck region. And just remember the fifth cranial nerve, that is trigeminal nerve. That is a sensory nerve basically, except the mandibular division. Mandibular division is also a sensory nerve, but along with there is a motor component in the mandibular division. Just forget about the motor component. The sensory components actually supplies the face. That trigeminal nerve has got ophthalmic branch, maxillary branch, and mandibular branches. So all the senses are carried through the trigeminal nerve, sensory nerve. And this is the facial nerve, is the motor nerve, which causes motor activity of the muscles. And there is abundant communication between the branches of these trigeminal nerves and the branches of the facial nerve, so that immediate effector response is achieved. Suppose something is falling in within your eyes, any dust particle or any hair, immediately you blink your eyes. This is called corneal reflex. Afferent is through the trigeminal nerve, ophthalmic division of the trigeminal nerve, and efferent is through the facial nerve. And in the brainstem, what we find? The nucleus of the trigeminal nerve and the nucleus of the facial nerve, they are very closely attached. And the communication in the face, there is wide communication between the branches of facial nerve and the trigeminal nerve. Where you can find V1 is the area which is supplied by the ophthalmic component of the trigeminal nerve. V2 is supplied by the maxillary component of the trigeminal nerve, and this is the V3, that is the mandibular component of the trigeminal nerve. Except this area of the angle of the mandible, this area is supplied by the great auricular nerve. Great auricular nerve coming from the cervical plexus, C2, C3 component. This is the lesser occipital, then we will get the greater occipital, third occipital, and this is the area of the neck. So, nerve supply of the face, they are basically sensory supply and motor supply. Sensory supply, they are by the mandibular divisions of the trigeminal nerve. Ache ki chobi? You can find there are the sensory nerves, supratrochlear, supraorbital, infratrochlear, external nasal, lacrimal nerve. These are all they are the branches of the ophthalmic division of the trigeminal nerve. From the maxillary division, we can get infratrochlear. This is the infraorbital branch, zygomaticofacial, and zygomaticotemporal branch. Similarly, from the mandibular division, we get the mental nerve, buccal nerve, and auriculotemporal nerve. So 5 from the ophthalmic, 3 from the maxillary, and 3 from the mandibular division. So 1, 2, 3, 4, 5. So these are the sensory nerves which are supplied. Whereas, ছবিটা আছে কি না, just remember this, that is the temporal, zygomatic, buccal, mandibular or marginal mandibular, and cervical. These are actually, these are the motor nerves, muscles of facial expression. They are supplied by the facial nerve. This is basically motor nerve. Again, facial nerve has got nervus intermedius. That we will know. So this, you can see, this is the supply from the extracranial part. One is going behind, posterior auricular nerve. One is going below, which is not present here, which will supply the other stylohyoid muscle, which is absent here. And here we are getting the temporal branch, zygomatic branch, upper and lower buccal branch. Actually, the buccal branch has superficial buccal, deep buccal branch. And this deep buccal is again divided into upper and lower buccal nerves. If you can remember, then you remember, otherwise forget it. And this, actually we can see the nerve is entering into a gland which is called parotid gland. And within the parotid gland, it divides into so many branches. And ultimately, it is coming out from the different parts of the parotid gland. The temporal is coming from above. Then other branches are coming from, like zygomatic, buccal, mandibular, they are coming from anterior border. And from the apex of the parotid gland, cervical branch is coming.